So we'll go into the session right away. And the very first talk is by Fairooz on retinoblastoma, diagnosis, treatment, and long-term outcomes. And let me remind you that she's the best person to talk about this, having years of experience of bringing people who were virtually blind with retinoblastoma back to seeing. Over to you, Fairooz.
Thank you. Thank you so much, ma'am, for this kind invitation. Thank you, Sharika, for putting this session beautifully well. And I'm very candid here. Dr. Padmaja holds a very, very great, space in my heart, right, as a postgraduate student. I remember her coming as an examiner, and I was given the responsibility to take her around in Mysore. And that's where we vibed and connected, and that relationship has been continuing. And she's really, really inspiring. She's one of the inspiring person in my life, and I owe it to you, ma'am, for everything that you have been encouraging me so far. And thank you today for having me here. Okay, going on to the topic, retinoblastoma, again, something which is very close to my heart. In the next 10 minutes, I'll try to cover because it's diagnosis, management, and outcome. Now, to treat retinoblastoma, it's just not me. I give the credit. It takes a village to treat a retinoblastoma patient. I, being an ocular oncologist, is supported by a medical oncologist, a radiation oncologist, neurointerventional radiologist, pathologist, without whom nothing happens. And whatever I'm presenting here today is all because of the studies that we could do, and thanks to the parents and, of course, the babies and my mentors who have led me through this journey. My main work in retinoblastoma is at Malabar Cancer Center in Kannur, Talsheri, where we have everything from the laser to the plaque brachytherapy, site care cancer hospitals with the oncologist that I'm associated, and Kidwai in Bangalore. So the most important thing that I want to highlight here today is it's happy news. Retinoblastoma is a good disease. It's positive. It's a curable eye cancer in more than 98%, and most of the time we forget about that. But the main issue is there is lots of challenges, and we need to close the care gap. It's basically we have to make it accessible, affordable, and available. And unfortunately, this disease is seen in the lower economic strata where they need a lot of financial help from people like us. Now, what I'm going to highlight here today is how to identify the disease. I know everyone knows about retinoblastoma, but this is mainly aimed to those who are new into ophthalmology. Applying the grouping, applying the staging, the treatment strategies, and finally the outcome. Most commonly, it's easy. White reflex, any child coming with a white reflex or a parent having a suspicion of a white reflex, it's mandatory to examine the child detail with the dilated fundus evaluation. Now, this child, a small boy from a Muslim family in Bangalore, they detected a white reflex. So, दादी ने बोला कि आँख में चमक है कि बच्चा स्पेशल पैदा हुआ है, it's a special child, there is a twinkle in the eye. So they sat with it, all right? So we have certain social beliefs in India. It's just not India, even in China, during my experience, where people ignore about it. When you have a squint, some people think, oh wow, it's a mark of beauty. Let the squint be there. It's luck factor. And these things still happen. We don't have to be amazed about it. But when we looked inside his eye, this is how it was. It was an endophytic RB, completely filling the eye. Well, we didn't have any other way but to enucleate. And well, the child is happy, the parents are happy because he was rehabilitated with a prosthetic eye. Strabismus. Any child presenting with the strabismus definitely needs a dilated eye examination. Now, the logic is very simple. We have a posterior pole tumor, might be covering the macular area, the posterior pole. There is no vision, so it's a vision deprivation squint that the child has it. So any squint child has to be evaluated. Cataract, straightforward white cataract, all right? Yes, perfect. But what caused the cataract? A tumor behind the eye can cause a cataract. Ultrasound B scan is a must. So there is a calcified lesion, intraocular with high spikes over here. Now, it is a masquerade. it can trick us. Retinoblastoma is not easy sometimes. It can really trick us. Unilateral glaucoma, unilateral ophthalmos, hyphema, hypopaeon, even phthisis bulbi. You have to ask for a history of, an orbital cellulitis like a picture in a child where the eye has gone for phthisis. Tumor necrosis, phthisis bulbi. So these are the different masquerades in retinoblastoma. A child, all these things, any problem such as these things, unilateral, always retinoblastoma or any other intraocular malignancy like ciliary body medullary epithelioma has to come into your mind. Now, how do we diagnose it? It's simple. Retinoblastoma is a clinical diagnosis. The other tools that you have are additional armamentarium. The most easiest thing that most of the clinics in the hospital has is an ultrasound B scan, which is good enough to diagnose a retinoblastoma intraocular. Examination under anesthesia is very, very important. Just don't see the posterior fundus and see, well, there is nothing there, but it's so important when there is a suspicion, take these kids under general anesthesia, examine 360-degree aura. It's just not aura. I don't stop at aura. I even go and see the ciliary body because there might be a child coming with hypopaeon where the entire fundus is normal, but you can find these tiny seeds in the ciliary body. Even that much, depression and examination has to be done, well documented, because it's important for grouping, staging, and the further follow-up in these children. We have the International Classification of Intraocular Retinoblastoma. I'm not going into the detail. This is for the postgraduates. You have to go and check it out. It's from A to E. Then we have the TNM classification. Now, what is important about TNM classification in retinoblastoma is that we have H, the hereditary component. It's the only cancer in the entire AJCC which holds an H, because retinoblastoma is a genetic disease, and that's how we actually emphasize the importance of hereditary in retinoblastoma. Now, going on to the treatment, well, we have primary treatment modalities and secondary or adjuvant treatment modalities. The primary is just 3, I would say: systemic chemotherapy, intra-arterial chemotherapy, and enucleation. Now, another variant of chemotherapy is the intraocular chemotherapy, which is not a primary modality, but it's just an adjuvant chemotherapy after you give the primary modality. Rest are laser, cryotherapy, and plaque brachytherapy. As I told you, systemic chemotherapy, intraarterial chemotherapy is the advanced, newer modality of treatment. Systemic chemotherapy has, excellent outcome when it takes care of the systemic micrometastasis as well, whereas intraarterial chemotherapy has the advantage that the chemotherapeutic agents are directly pushed into the tumor, so the outcome is better as far as group D eyes are concerned. Now, transpupillary thermotherapy is an adjuvant treatment where you chemo reduce the tumor size. When you have something active, you just go and treat it. So this is a fovea sparing transpupillary thermotherapy. With the diode laser, the damage to the retina is much less than a green laser. So that's why I use in my practice. Now, this is a patient with a peripheral lesion which was cryoed. Rest of the things, everything is done. This is after cryotherapy and intravitreal topotecan injection, completely regress. This is a recurrence after treatment with systemic chemotherapy, cryotherapy, and intravitreal topotecan 3 times. So with the advent of intravitreal topotecan, I have started combining these with either with laser or cryotherapy, because I feel once the tumor is stimulated by a laser or cryotherapy and then putting a chemotherapeutic agent over it really helps in the response. And I found that difference in my practice. 10-year-old boy, bilateral hypopaeon, 6 chemos completed elsewhere. They said he might have to go for bilateral enucleation. That's when the parent came to me. This eye is already phthysical. So my challenge here is to save at least one eye. That is the right eye. Now, his fundus is perfectly fine. Okay, posterior fundus is fine. Periphery is good, as you can see here, only scarring. What he has is this ciliary body particles, and it's just not here. He has everywhere. He even has superior, and this is what is spitting into the anterior segment every time. When you look, everything is silent in the posterior pole, but this is what he has. So I had to go ahead with 8 intravitreal. Okay, what happened? Gone? Yeah. Thank you so much. So the child, what I had to do was, yeah, I'll just quickly take it. Yeah, so 8 intravitreal, what? Yeah, even it's going off here. I'll tell you the story. So he received 8 intravitreal topotecan. He received 3 intracameral topotecan in the same eye. Then he had a ciliary body component inferior, which we had to give plaque brachytherapy. And after plaque brachytherapy and these intervention, he developed a cataract. And then we have to go ahead and do a cataract surgery. And well, we were kind of, one second. Oh, when we are taking that picture, that slide, no? Then we'll skip that slide? Okay. I'm sorry. Okay, let's skip that slide. 1 second, huh? I know the slide, yeah. This slide also? Yeah, I'll just, is it same? No, the previous slide is the one, culprit. This is okay? Yeah. So this is how he was finally with a 6/24 vision in the right eye. Crossing fingers, mashallah, hope he goes like this. With 5 years follow-up, he's doing fine. Anytime they can recur. Oh. No, not that one. I'm so sorry. Something is... Can I do the next one? Oh, I'm so sorry. Will it play? No, it's not playing anymore. It is not keynote, it's PPT. Maybe the next person want to present, I can take it later, ma'am, without any delay. Yeah.
Maybe
Yeah.
do that. Then I'm sorry, Fairooz.
That's okay.
I hope it gets sorted out.